Hi everyone, thank you for having me tonight. I'm here to present you what I've been doing here the last couple of months during my precepted leadership experience with Dr. Simmons. So part of what this experience has been, or the purpose of this experience has been to develop a project. So for the development of that project, I needed to do an organization assessment. An assessment of the college, and then an assessment narrowing down to the nursing department. So my goal here, together with, in collaboration with Dr. Simmons, was to come up with a project that can be useful for the unit, for the nursing department. So I looked at all of your important reports. I did a lot of observation, interviewing, curriculum, and this generated a 20-page report that we really looked into and analyzed and looked to see where I can be useful, basically. So these are some of my findings. In your CCNE report on page 40, somebody here wrote this. Healthcare delivery continues to move from an inpatient to an outpatient setting. I agree. Patients exist more out of the hospital than inside the hospital. That was a quote from one of our faculty here. More than half of all surgical procedures in North America are in an outpatient or in ambulatory centers, according to the Center for Disease Control. And this last quote is from the Carnegie Foundation report, the 2009 report, titled Transformation, A Call for Radical Transformation, Educating Nurses, written by Dr. Bender. And it says that, basically, that there's a shift of care going more into home and more into the community. So I found that quote very significant as I'm doing my research and analyzing this assessment that I'm doing. The last part here is from the Institute for Health Improvement, and I've printed out their enterprise. Their enterprise model. It's a framework that they are encouraging us to use, and basically what it is a different way of thinking of the healthcare system. It's telling us to try to formulate integrative collaboratives. So the healthcare system is so many different facets, and what are we doing to come together and formulate collaboratives so that we can target what they call the triple aim. And if you go into it, there's such a wealth of information, and there's a beautiful video that shows you. But this framework helps us to think of the healthcare delivery system in an integrative way, where we can bring academics, acute care, community, schools, public policy, and everything, all the different facets that have to do with the healthcare delivery system, bring them together and come up with ways on helping the aim, which is experience of care, population or community, and cost. So basically here, the aim with this framework is telling us how can we increase patient satisfaction, decrease costs, and at the same time pay attention or increase our population's health. So this should be our target, is what the framework is talking about. Okay, and this is the website, and if you go into it, there's a beautiful 7-minute video that talks thoroughly about this framework.
Oh, video. Okay, there it is. We need to go into it.
Okay.
Lucia,
Yes.
this framework, I think you just said it, this framework looks at integrating education across healthcare disciplines?
Yes, it looks at education, it looks at community, it looks at acute care settings, it looks at all the facets that have to do with the healthcare delivery system, and we're one of those facets because we're educating nurses.
But it's not just for nurses?
It's not just for nurses,
Okay.
no. So I looked into our report, The Future of Nursing, Leading Change, Advancing Health, by the IOM, Institute of Medicine, and they also say, gosh, there's a shift towards community. Please put an emphasis on community and public health. This is the call that they give us in the chapter that they talk about transforming education, nursing education. So more research. So I did a lot of research, and some of the articles are up here. One is called Baccalaureate Nursing Students' Intention to Choose a Public Health Career. And this was a very interesting article that is reporting on a quantitative study. And they are looking to see how many students are interested in public health when they are ready to graduate. They looked at juniors and they looked at seniors. They looked at 354 students. So they did a survey and they found that only out of these 354 students, only 23 chose public health or community health right after graduation. 25 chose public health or community health a year after graduation, and 57 chose community health or public health more than 1 year after graduation. Now we have our speculations on why that is, right? The author goes into a few Larson and colleagues, they go into quite a few reasons, but the most significant reason that I found and that I agree with is that there is this notion that you cannot graduate and become a community health nurse. And that's, when I studied, that's what it was. But there is good news, because we need community health nurses. There is a huge demand for them. And now there are initiatives and internships that are happening throughout where we are welcoming graduate nurses. So this is a notion that we need to start to get away from and encourage the new graduate nurse to please come into community health, because we need you. Okay, so that's why that quantitative study was so significant. And the quote that she gives us is, please, faculty, explore opportunities so that students can get excited and become enthusiastic, hopefully, of community health. So the next article that I want to bring up is called Essentials of Baccalaureate Nursing, Education for Entry-Level Community Public Health. And here, this article is written by the Education Committee of the Association of Community Health Nurse Educators. This is an association dedicated to excellence and education of community health. And what they let us know in this article, they give us 15 essentials that need to be included into the community health curriculum. And why this quote is significant is because within the article, under the subtitle Educational Issues or Educational Problems within the curriculum are, or could be, some of what we're seeing here, are we putting these essentials across a curriculum? So are we giving that to our students, is what they're asking us. Are we integrating community health concepts and ideas and enthusiasm within the whole spectrum of the curriculum? Or are we just doing it in the community, which is mostly at the end of the coursework for most programs, right? So that's what they're asking us. So we see a trend here in my research, in the findings, that eventually go along the lines with my expertise, which is public health nurse, certified specialist. So I'm your girl to look at this and to say, you know, let's see what we can do, okay? So we're all familiar with this picture, right? Yes, and this is a lot of what we do, right?
I don't do the rooftop thing.
No more rooftop.
No.
So, what can we do? What can we do in order to integrate community health within the whole spectrum of the whole curriculum in a baccalaureate program? These are things that we can do. The orange ones are suggestions from the IOM, from the chapter of Education Transformation, and the green ones are mine. I'm not going to go into each one, but I will go into healthcare disciplines for a moment there, because in my experience and what the literature says is that students are graduating not understanding the roles of the interdisciplinary team or the multidisciplinary team. And I see that a lot in seniors that come to me when I take them out for the community experience. They oftentimes don't know the role of the PT and the OT, and it's a good learning experience, but we have opportunity to make sure that students know the roles along the way of the different roles of the interdisciplinary team. So IOM encourages us to look at that further. I want to talk about patient satisfaction because it's one of the aims here, but it's also a quality measure, and it's also how we're getting paid, right? It's also something that CMS is looking at in terms of reimbursement, and it's actually very essential. And how are we going to teach students about patient satisfaction? So the literature says that patient satisfaction can come in with patient integration, getting the patient involved, getting the patient to verbalize his preferences, his values, his concerns, which coincidentally is also part of evidence-based practice. So we look at that and we say, that's how we can get students excited about patient satisfaction. Also reminding nursing students that our patients are our consumers, are our customers. They are essentially customers. And if we can start to look at them that way as clients, we can potentially increase patient satisfaction, which is very significant now in the literature and in terms of reimbursement, like I said. So if we look at this whole spectrum here, the biggest goal here for me when I put this together was to promote the role of the community health nurse. So to integrate what the title of the project, community integration. Community integration's goal is to promote the role of community health nurse because we need them. So I looked into your curriculum a little bit, and I started with the first course here, 311. I wrote some possible objectives. I went into the content, and I took out different topics that would pertain or that you can possibly integrate community health within them. And in the notes section of the PowerPoint, there's details and page numbers and websites as to how these topics can get the community health view. And also the global view, the national view and the global view, because that's another article that I have up here, says to prepare community health nurses, we need to prepare them with that global national view of what our people are, what our patient population is.
What under prep for class, second box is WOCN?
WOCN is Wound Ostomy Certified Nurse.
Thank you.
And if we go back to the previous slide, when we talk about integration and talking about healthcare disciplines, this can be an opportunity to bring in a WOCN and do the wound care lecture and do the skills lab, for example. You know, that would be an opportunity to follow what IOM tells us to do, to attempt that integration. So, like I said, within the notes you will find more information about each topic. This is when we begin to see some of our national objectives. Hypertension, mental health, right? So I'm going to suggest that Healthy People 2020 be part of the reading. Part of the reading, because this is where we begin, and it's just 2 pages. Healthy People 2020, it's a list, and it's just 2 pages, and just to get them to start to look at disease process in a more national, in a more global way. And my hopes is that, gosh, if they begin to realize that this disease process is a national problem, they can start to get that community health view or that community health training that we need them to get. Okay, and some of the reading in the textbook that we use, the Invictus and Workman, there's some community health concepts in there. So, and I've written up the pages, and I've written the websites that I'm going to recommend that they be inputted at least into the recommended reading, because these websites are phenomenal in terms of helping them understand some of these disease process. They have webinars, they have diagrams, they have all kinds of helpful things that can go into at least the recommended reading. Because we know what kind of population we're teaching now. We're teaching digital natives, right? We're teaching students that are totally online, constantly. So we need, at this point of the game, we need to be giving them very, very good, helpful, reputable resources as part of their reading. This again, here we see some of our objectives, the Healthy People 2020 objectives. Diabetes, HIV, cancer are some of them. And definitely, healthy people can be part of their reading. Again, Invictus and Workman do bring up some community aspects to these disease processes, so it helps us. And a lot more in the notes. So 316, again, same scenario. I looked at I wrote out possible objectives, the topics where we can try to focus community in, and some of the reading. And then again, in the notes section, you will find websites to each particular disease process here, where you can either make it as recommended reading or required reading, or at least just to give them that community aspect to each disease process. So why do we do what we do? Why are we doing all this? Right? Who's our priority? The patient. My patient here. This is what I want. An independent patient. Right? But do we get that? Not always. From the home to the hospital. So what we know about the patient when he goes from the home to the hospital is that they become dependent. Right? They become dependent, and how do we help them out of that? Especially our seniors, where we have to focus a lot because of what we expect in the next 20 years, right, with the population. But this is being looked at a lot in research and in healthcare, and we know that this is what's happening in the acute care setting, and we want to get them to this. So there's a transitional period that happens. There's something that gets lost along the way. That seamlessness connection or transition from the acute care to the community is lacking, is missing, or has been. No more. Now we have a new model of care that I want to introduce to you today. It's called the transitional care model. And this is cutting-edge, evidence-based solution. This is going to help us through that transitional period, because they finally found out that this is where patients are getting lost. This is where it's happening. So therefore, this program came about. Within the notes section, there's a lot of details as to how it came about, the history. It came from the University of Pennsylvania. So, and the goals are to improve quality, outcomes, and cost. Okay? And like I said, transition from acute care to the home. That's really what they're looking at with this model of care. And these are some of the goals, again: education, communication, continuity of care, community resources. This is what's being looked at within this model. IOM talks about this model as being an exciting way of practicing today within the 21st century. But also it talks about what's relevant to us here as educators is that it's a great opportunity for clinical placement also for our students. So we look forward to that. The nursing goals of the transitional care model. Okay, and the transitional care model, the person that leads it is the nurse practitioner. So what happens is that the nurse practitioner meets the patient in the hospital setting, is involved with discharge planning, gets familiar with the whole experience, whether it be the hospital, whether it be the nursing home, whether it be the rehab, wherever the patient has been and has had their experience as a patient, they're going to go there, participate with the discharge planning, which we know is a problem. They are going to help with that. Finally, we get someone to help with the discharge planning in a thorough way where our patient is not going to get lost when he gets home. Right? We do a lot of coordination with the transitional care nurse. I'm a home care nurse. The home care nurse does a lot of coordination. We do joint visits. We set up goals for the patient. We educate the family and do a real collaborative effort is happening here with the nurse practitioner that is the transitional care nurse.
Did it start already anywhere or not?
Yes, it has started. We actually were part of the pilot for this program about 2.5 years ago at White Plains Hospital, along with Empire Blue Cross Blue Shield. And now it's off and running. It's a framework, so people are taking it and making it their own. So however it fits within your institution, you take it and you make it your own. This is the model the traditional model that came out, but you can really make it your own depending on your facility.
So the nurse practitioner is a facilitator, right?
Yes.
Is she assigned by the hospital, by the VNS, or by any other
Depends. The hospital can have the program. The VNS can have the program.
The pilot program now, how does it run?
The pilot program is over now,
Okay.
and now we have our own transitional care program. We have a nurse practitioner. She's part of that program, and so it's independent. And the great thing about it is that CMS, Medicare, Medicaid, is now acknowledging that this is important, and they are reimbursing.
There's data, I came across for another project, that when transitional care models are used, it saves Medicare, CMS, $5,000 per beneficiary. That a study was done in Colorado that saved the University of Colorado Medical System $250,000 in 1 year. And that and there's another study in Madison, Wisconsin, 33% fewer hospitalizations and $1,225 cost saving per patient.
It totally fits with the Obama model now, that kind of hospital will be liable.
Definitely cost
back, right?
And
It also fits with
Right.
certainly this Iowa report, but the future of nursing report,
Right.
because to maximize 3.1 million registered nurses in this country, how do we get here? How do we have the NP being
Part of that problem.
the coordinator? How does that happen legally from legislative perspective, et cetera? Because there's still
Exactly,
there's
that's
still
what I'm asking.
barriers
That's
there,
why I wasn't clear if it's actually she's part of
Yeah.
VNS, because there are different companies. VNS is not the only company. So would the company itself send somebody to the hospital, hospital has to approve this person, and then this person, I guess, directly sends the patient to VNS. But there are other companies, so I'm just
There are
curious
other
legally how
companies.
does it, right?
Right.
And at the conference I went to, Marianne Christopher from the VNS spoke about this, and they're doing it according to population health. So they now have a program, I'm sure you know, for congestive heart failure patients. They have a patient, they have a whole one for falls. Doesn't matter.
Which VNS is it?
This is VNS of New York.
Okay, because VNSW, I don't know that they do a transitional care model, but I don't think they're, anyway, I'm being recorded. So I think they're moving in that direction. They have CHF, they have population health.
Yeah, they have partnered with their payment people. So that this way the goal is to make them a partnership in this collaborative method rather than an outside entity that they have to serve.
And this hire these people will pay for themselves 3 times.
Absolutely.
with the cost saving.
Absolutely. Yes. And that's a big goal of this is cost saving.
What about the patient who's not going to go home with any kind of home care services? How does this model fit for them so that they'll get adequate discharge planning, teaching, and follow-up, so that they don't go back to the hospital for readmission?
Well,
It falls on the institution.
That's a
right,
good
that
question.
falls on the institution,
I know.
and in the discharge planning, if a patient is not appropriate for the community, that should be determined and looked at by the transitional care nurse and looked at further to say, does this patient really belong in the community yet? Placement might be an opportunity. It might be a patient that needs to go to a nursing home, for example.
So it would be a nurse practitioner at the hospital
It,
that would be the facilitator.
I think that's the same question.
Yeah, it can be either provided from a hospital, from a home care agency, from a different entity. It's a framework, and really, and this main framework, which is the main one that got patented. I'm thinking it got patented. I'm not sure, but
It did.
it copyrighted. The nurse practitioner is in this framework. However, when we look at the rest of the literature, and there's a transitional care management article here that goes into it further, but it can be the NP, but it can also be a psychologist. It can be a social worker. So like our programs in Queens, we have the social workers that go out to the hospital and assess the patient and get involved with discharge planning. So they're looking at it. They're looking at that. They're looking to see if the patient is appropriate to leave the hospital or the rehab or the nursing home. Are they ready? And if they're not, then other options need to be available for them.
There's the big push for 2014 for prevention of reentry within 30 days. So a lot of the hospitals are employing, because sending the patient home and they end up getting readmitted within 30 days doesn't save them any money. It actually gets them fined. So they're looking to see what they need to do to make sure, even if they're not going home with home care, are they going to an environment that's actually going to take care of the issues to prevent that readmission.
Right.
I'm going back to Kathy's point, because I'm thinking of what an opportunity this is for nursing, in that there are plenty of patients who should be discharged home, who don't need to be placed. But you could have some concerns. I mean, I hate to do this, but I'm going to. My dad had a GI bleed. He's perfectly capable of going home. That's fine to his home. But having somebody make sure he gets his meds. I mean, he understands, comprehends, because it's very confusing. So what an opportunity to prevent a problem before it actually appears. Because folks like my dad, who look fine, there's no reason why you would think he would have any needs. Those are the people we have to worry about, because we do it.
Absolutely.
And we think of home care, we think of community nursing as they need more because they have, I don't know, a Kuber's ulcer or mobility issues. There are a whole lot of people who need more that we don't think about. So I think this is, because I'm thinking of the folks that don't need. Look at your dad. Which is 2 broken wrists, for God's sake.
They sent him home.
Yes, of course.
Have a good life.
With your mom.
With your poor mother.
Because there's an idea.
Well, I mean, I remember in rehab, we had this